So I was going to talk about the case for induction chemo in head and neck cancer. The induction chemo is clearly indicated for nasopharynx cancer. I won't be talking about that, but I'll be talking about head and neck cancers of the other types. Sorry. See if I can move on here. So when we think about chemotherapy for head and neck cancer, really everything is built on platinum-based chemotherapy. Cisplatin is kind of the base upon which we build every regimen. The other drugs are important. I would say the taxanes are probably second in importance. 5-fluorouracil has really fallen out of favor, primarily because the mucosal toxicities you get with 5-FU are pretty substantial, especially when you add that to radiation therapy. So 5-fluorouracil has a role in the palliative setting, but we try not to use it too much in the curative setting. Methotrexate, an old drug that does have efficacy in head and neck cancer. And then the newer, more exciting drugs are the monoclonal antibodies. So drugs like cetuximab, which targets EGFR, pembrolizumab and nivolumab, which target the PD-1 axis in head and neck cancer. So just taking a step way back a couple of decades, this is the U.S. head and neck intergroup trial that really established the role of chemotherapy concurrent with radiation when a patient is not operable. So what this trial showed was that if you gave cisplatin with radiation therapy, that patients did better. You can see that their overall survival was marginally better, but was statistically significantly better. And that trial really established this as the standard of care. Now, when you look at the disease-free survival curves, those were also better when you gave chemotherapy with radiation. But what you'll notice is there's a distinct disparity between the overall survival and the disease-free survival. So patients were living longer without disease recurrence, but they still were dying at a pretty significant rate. And the question really is, why is that? And it probably has to do with comorbidities that patients with head and neck cancer have. So a lot of them will have coronary artery disease, other vascular disease, things like stroke. So that was one interesting point from that study. So in terms of induction chemotherapy, what is the rationale for doing chemotherapy before chemoradiation? So we know chemoradiation's better than radiation alone, but would it make sense to give chemotherapy first? And some of the rationale for that are, could you improve survival by doing multi-agent chemotherapy? Could you control early metastatic disease? So patients who have subclinical micrometastatic disease, would giving chemotherapy early in the course of their treatment be of benefit? Could you decrease the patient's primary tumor with the potential of reducing how much radiation you get, right? As was just mentioned, if you give large doses of radiation to large fields, the long-term morbidity can be substantial. And could you potentially enhance local control by giving a lot of chemotherapy up front? Those were a lot of the questions that were being asked. So in 2007, there was the TAX-324 study that was presented to really quite a bit of fanfare. What they did in this trial was they took a 3-drug regimen of Taxotere, cisplatin, and 5-FU and compared it to cisplatin and 5-FU before you got chemoradiotherapy. And these were in patients who were surgically unresectable, and they were given 3 cycles of so-called TPF. And what you can see in the study is that patients' overall survival, if they got TPF, was better than if they had just cisplatin and 5-FU alone. But I think as exciting as this was, and it was actually a plenary presentation at ASCO back in 2007, it still didn't really answer the most important question is, if you give induction chemotherapy before chemoradiation, is that better than just chemoradiation alone? Because a 3-drug induction regimen is very toxic. I think if you've ever seen someone get TPF, you can see that a lot of them, by the time they're done, are beat up enough that they may not be in great shape to get chemoradiation. So what you don't want to do is prevent them from getting to a definitive approach. And so that was the question that was sort of floating out there for a while. And so in 2014, the data from the DECIDE trial was presented. This took 285 patients who had N2 or N3 disease. They were randomized to induction chemotherapy. They got TPF for 2 cycles and then got chemoradiation, or they got chemoradiation therapy alone. And the primary endpoint in the study was overall survival. A lot of excitement about it. I think everybody thought, for sure this is going to be a positive study. And lo and behold, there was no difference. The patients who got induction chemotherapy did not live any longer than people who got chemoradiation alone. Again, kind of confirming the standard of care, which was chemoradiation. One interesting, I think, piece of this study was the distant recurrence. Patients who got chemotherapy before chemoradiation had a lower incidence of distant recurrence. Another trial, the Paradigm trial, basically confirmed what the DECIDE trial showed, was that 3-year survival was exactly the same if you got induction chemotherapy versus chemoradiation therapy alone. So the case for induction chemotherapy was really sort of, I don't know, it seemed like dead at the time. I think we had a lot of enthusiasm for induction chemo in the medical oncology side before the DECIDE trial came out, and then we were left kind of stumped. Well, how do we improve outcomes now that giving a lot of chemotherapy doesn't seem to benefit people? I think you have to look at the data a little bit more closely to understand maybe why these trials were actually negative. A lot of it has to do with the confounding effect of HPV-positive tumors. So 61% of patients in the DECIDE trial had oropharynx cancers. And if you remember, most oropharynx cancers are HPV positive. So in this trial, 80% of them that were tested were HPV positive. In the Paradigm trial, a companion study, 56% of those patients had oropharyngeal primaries. And the HPV status was not known in that study, but you have to assume that the majority of those were HPV positive as well. And the reason I bring this up is because when you have HPV positive disease, you can probably cure those patients with radiotherapy alone. You can make an argument that they don't even need chemotherapy sometimes. So what they did in this study was a trial that was enriched for patients who were going to do well no matter what you did. In retrospect, what we should have done was enrolled patients who we knew were not going to do well no matter what you did. And those were the patients that you should probably give induction chemotherapy to, or at least consider it. So I think the number of high node station patients were also low. So the patients who you would think would benefit from systemic chemotherapy up front, those with N3 disease, were, in my mind, underrepresented in these trials. Only about 10% of the patients in the DECIDE trial had N3 disease, which you could argue those would be the ones that would benefit. So as was alluded to earlier, I think our goal in treating head and neck cancer patients who are going to get chemo and radiation is to reduce the radiation that they are exposed to, either in terms of dose or radiotherapy field size. So this was an interesting study, took 94 patients that were treated with induction chemotherapy prior to chemoradiation, and patients who had a greater than 50% reduction in the sum of their tumor diameters got 7,500 centigrade exclusively to gross disease. They did not get extended nodal irradiation. Patients who had a less than 50% response to induction chemotherapy got gross disease radiated, and then the next nodal station was also radiated. In this trial, 41% of patients had a greater than 50% reduction in their tumor size. So patients who received extended nodal radiation, as you would expect, were more likely to have a G-tube placed during treatment and remained G-tube dependent after they finished treatment. That's one of the kind of the complications that we don't like to have patients get, is a G-tube, but also prolonged G-tube dependence. It's fine to put in the G-tube to get them through chemoradiation, but ideally they would not be G-tube dependent for nutrition going forward. In the study, there was no difference in overall survival, and it didn't seem to compromise outcomes, and probably resulted in decreased long-term toxicity. That's an important thing for patients' quality of life. I mean, I think we've all had patients who become G2 dependent and they never are able to eat again. And so if you could spare someone from that fate, I think that's a really important outcome. This is granted phase 1, phase 2 data, so take it for what it's worth. We probably need to do a phase 3 study for this, and we are. This was another study, ECOG 1308, was a phase 2 study of 90 patients who had HPV-positive disease, were given 3 cycles of induction chemotherapy, and patients who had a complete response received 5,400 centigrade. Patients with a less than complete response received standard dose, 6,900 centigrade. 70%, interestingly enough, 70% of patients in the study had a complete response, and in this trial, 94% overall survival. One of the key points from this study for me is that at 12 months, solid food dysphagia was substantially lower in patients who received a lower radiation therapy dose. So again, this phase 2 study is kind of indicating that if you are able to reduce the radiation therapy dose because you've given induction chemotherapy, person's quality of life will probably be substantially better long term. So just a couple of cases to kind of give you an idea for where I think about doing an induction chemotherapy, and I'm glad I have colleagues at LSU who let me do this kind of thing because I think we get good outcomes from this approach. So this first case is a 39-year-old man who presented with nasal congestion and progressive proptosis. You can see his left eye is deviated laterally and definitely has proptosis. He also had nodal metastases in his neck. Biopsy of the neck mass showed a squamous cell carcinoma with features suggesting that he had something called a sinonasal undifferentiated carcinoma, but it was felt ultimately to be just a classic keratinizing squamous cell carcinoma. So this is his MRI, and you can see he's got substantial filling of his sinuses, and the mass is what's causing deviation of his eye. Let's see if I can get this to play.
Towards end of December. Towards end of December.
So, yeah, sorry about the audio. That was his PET scan, and you could see he had substantial FDG avidity in the nasal cavity and in the neck. He was evaluated by ENT and neurosurgery, actually. He was judged to not have distant metastases, but was not felt to be an upfront surgical candidate just because of the extensive nature of his tumor. So our radiation oncology colleagues saw the patient and felt that based on the location of the tumor and its proximity to his eye, that he wouldn't be a good upfront radiation therapy candidate. Vision loss would be substantial in that eye. So we elected to do chemotherapy. So I gave him cisplatin and docetaxel for the first 2 cycles, and then for the first cycle, and then for the second, third, and fourth cycle, I gave him 5-FU with the cisplatin docetaxel. And I'll talk about why I did that in a second. He had excellent end organ function and had good tolerance. He was otherwise a very healthy person, so an ideal chemotherapy candidate. So this is before and after getting chemotherapy. You can see that the proptosis resolved, the eye deviation resolved. He was able to see out of that eye, and his double vision resolved as well. The result on the MRI was also equally impressive and gratifying to see. You can see here before we started and then after. He had a substantial reduction in the size of his tumor. So he underwent a resection. The final pathology showed just a few areas of residual squamous cell carcinoma. He didn't have a complete pathologic response, but certainly a very good partial response. Postoperatively, we were able to give him chemoradiotherapy to the primary site and his residual neck disease. His course was complicated, definitely complicated. He had CSF leak, meningitis, was in the hospital for several months after, but I just saw him 2 weeks ago in clinic. He's now 2 years post-treatment, still doing well, normal function. He has a frontal skull defect that needs to be fixed, but extremely gratifying to see this guy who we thought may not make it appears to be in remission still. So the second case I want to present, this is a case that's still kind of ongoing in terms of treatment. This is a 62-year-old man with a history of trauma to his right orbit about 20 years ago. He developed progressive facial swelling, purulent drainage under his right eye. He had a PET CT scan that showed no nodal disease or metastatic disease, and he had nasal endoscopy that showed atypical, moderately differentiated invasive squamous cell carcinoma of the maxillary sinus. So this was a picture of his face when he came to see me, and you can see very impressive swelling in his face. He has an ulcer that was draining purulent material from under his eye. And you can see on the CAT scan, this is the mass that's basically filling his maxillary sinus with communication out onto the skin. So after a multidisciplinary discussion, the extent of his disease was felt to be substantial. Won't go in the details why, but very substantial disease. And he was not a very good surgical candidate. He had substantial medical comorbidities that weren't well controlled. Poorly controlled diabetes being the main one. So I think for that reason alone, he wasn't felt to be a good surgical candidate. Radiotherapy up front was also felt to be potentially quite toxic, and so we proceeded on with chemotherapy for him. Because of his medical comorbidities, I only gave him cisplatin and docetaxel. I did not utilize 5-fluorouracil. We were a little bit concerned too about his compliance with therapy and going home with an infusion pump, which is what is required with 5-fluorouracil. So just a word about toxicity considerations. There are two classic types of induction chemotherapy: docetaxel, cisplatin, and 5-FU, given in slightly different doses, slightly different schedule. But if you give all three drugs at the same time, the rates of grade 3 or 4 neutropenia are quite high, 83%. 12% of patients will have febrile neutropenia. The mucositis rates are also very high. Grade 3 to 4 mucositis occurs in about 37% of patients with this 3-drug regimen. You can actually kill people because of it, quite frankly. There's a 2 to 5% rate of death attributed to chemotherapy with TPF. So if you're going to use TPF, you have to do it with a lot of caution, and that's kind of the art of oncology. It's not prescriptive that you have to do TPF. You can start low, slowly escalate, and that's what I've been doing over the years. So for me, it's about staged dose escalations. I don't get into a rush of trying to give everybody TPF for cycle 1, because if you give them cycle 1 TPF and they have a really bad morbid outcome because of that, they're probably not going to be motivated to continue on with therapy. So I do stage dose escalations. I usually start with 2 drugs before I add the third. Sometimes I will just do 2 drugs. I won't go to the third drug. And I never go above 75 milligrams per meter squared on the chemotherapy, on the cisplatin dose. I find the regimen that includes 100 milligrams per meter squared is quite toxic. The number of cycles you give is not defined. You can give 3 to 4. Sometimes we'll go up to 5 if the patient's responding quite well. The key thing for me is I don't want chemotherapy to prevent a patient from getting on to a definitive therapy. So to get to radiation oncology, to get to surgery, I don't want chemotherapy to prevent that from happening. So this is before and after photos of this patient. He got 4 cycles of chemotherapy. Here's before and after. You can see the ulceration on the skin went away, and the size of the tumor changed substantially. You can see he still has a defect in his sinus there, but a significant reduction in tumor burden. And his case is actually now back in the hands of my colleagues, surgical colleagues, so we'll see what we decide to do here. Just a word about immunotherapy combined with chemo. We're using immunotherapy combined with chemotherapy now for, it seems like everything. Is there a role for that in head and neck cancer? And I'm not really sure yet. We don't have the data to say that there is a benefit for immunotherapy in the induction setting. There's definitely a role for it in the metastatic setting, but in the induction setting, there's actually some hints that the toxicity is enhanced if you add immunotherapy to chemo. So it may not be a good idea to do that yet. More to come on that. I think that's where the field will be going in the next 5 years or so. So in terms of induction chemo, where we're at with it, so for sure you give it in nasopharynx cancer. For all the other head and neck cancers, we're not sure. There's no clear improvement in overall survival. I would argue that there's a pretty good rationale to suggest that you can control micrometastatic disease, especially if you have N3 disease. You can certainly decrease the primary tumor size, which may reduce the radiation fields. We may be able to reduce the long-term toxicity by doing induction chemo. And in some sense, you may render what is unresectable disease resectable. So the first case I presented, that patient would have never been able to go on to a definitive approach. And with the use of induction chemo, he got there. The other important thing for me, I practice at University Medical Center primarily, and we have a patient population that has a lot of uncontrolled comorbid conditions. A lot of times they present to our hospital, to the healthcare system, because of their cancer. And then lo and behold, we find that they have poorly controlled hypertension, hemoglobin A1Cs of 10, poor insight into managing their own health. And I think chemotherapy allows us in a way to optimize their medical conditions while controlling their disease and get them to a surgical procedure or radiotherapy. I think future state where we're going is that immunotherapy alone perhaps will have a role in induction, so not even giving chemotherapy, or using immunotherapy with dual agent chemo. Just to finish up with a sort of a philosophical thought, and this has been alluded to as well, I think the key with head and neck cancer management is multidisciplinary input. All of these cases, I would argue, need to be discussed, not only amongst the surgeons and radiation oncologists and physicians, is that you also need to have our cancer center nutritionists involved early. Nursing support is extremely important. The value of chemotherapy nurses in educating patients during the course of their chemotherapy is really, really important. It can't be underemphasized, because as physicians, we see the patient for a 30-minute clinic encounter, an hour clinic encounter. The chemotherapy staff is the one who's interacting with the patient for hours while they're getting their infusion. So really important to have their input. For us, especially in UMC, social work support is really important. Patients are coming every day for radiation therapy, coming 5 days in a row for chemotherapy. So transportation and medical assistance is important. And then obviously the opportunity to enroll patients on clinical trials, extremely important. So that's the end of my talk, and then I'll pass it on to Dr. Vaititis.